Well, welcome everyone. Thank you so much for joining us. I'm Megan. I'm working as the event coordinator at the Pituitary Foundation. And before we begin this session, I'm just going to run through some housekeeping. We have enabled closed captions, so if you'd like them, you can just click the CC button at the bottom of your screen. And for those of you not familiar with the Pituitary Foundation, we provide support for the 70,000 and more people in the UK who are affected by disorders of the pituitary gland, as well as their families, friends, and carers. We want to ensure that every person affected by a pituitary condition has a timely diagnosis and access to high-quality treatment, information, and support. We have a dedicated nurse helpline, online and printable resources, and we work with leading medical experts, some of whom are joined us today, to improve patient care. I'm really excited to be holding this talk as part of our Pituitary Awareness Month programme. So for those of you not using visuals, I am a white young woman in her mid-20s. I've got blonde hair tied back in a bun, and I'm wearing a very warm and comfy blue hoodie today. This session will be recorded and will be available on our website later in the year, probably towards the end of November. No one's faces or comments will be visible unless you want to ask a question and put your camera on. And we want to ensure that all of our events are welcoming and accessible for all, especially as we may explore personal experiences in this session. So to this end, please can you remain on mute when you are not talking to manage background noise. You do not need to have your camera on if you prefer not to, but of course it's lovely to see those who feel comfortable with it. You may wish to add your pronouns to your name as well, so we know how to refer to you. As you can see, some of us have included ours, but it's not a necessity. To chat, please use either the chat bar or raise your hand at the end when we get to the question and answer portion. I'm sure Indy as well will be happy to take questions throughout. Please just keep putting your questions into the chat so we can keep an eye on it. Please be respectful as people share personal views and experiences. So we should finish around 7:30, but this session is scheduled until 8 o'clock in case we run over with extra questions. And if you need to leave the session early, this is completely fine. Don't feel like you need to say anything, you can just head off. And I think that's everything from me. Great, thank you for listening to my little spiel at the beginning. And I will hand over to our brilliant speakers for today's session for parents of hyperpituitary children. We are joined by Dr. Indy, specialist endocrine nurses, Charlotte and Helen, and a PhD student and parent to a child with hyperpituitary, Yolanta. So I think Indy is going to start off this session today. Over to you.
Many thanks, Megan. Maybe I should do a little round of introductions for those people who've taken all the time quite late in the evening. So many thanks for joining in. So my name's Indy Banerjee. I'm a consultant in pediatric endocrinology. I work in the Children's Hospital in Manchester. And with me are my very able specialist nurses Helen, if you give us a wave, and then Lottie, and so they manage our some complicated young people. I can see, hello, is that Alex's daughter? Very nice to see you. Hi. And we also have Yolanta, who I connect in a different way, but at the end of the day, she's a mum of a young person. So I think we're here to learn from you. So please interact. You've taken the time in the world to come and be here on screen. It's a real opportunity for us to reach out to you. And as Megan says, the Pituitary Foundation is the perfect vehicle to reach out and share information, because a lot of the information is just not reaching families and parents. So I'm going to share my screen. I have a small little presentation, and it's just to raise a bit of awareness, but also set the scene. And I'm hoping you can see my slides. So Pituitary Awareness Month, as you know, is in full swing. So, any kind of support is very welcome. But I'm just going to talk a little bit about the pituitary, just set the scene. And this is where I work on a very bright day, which is actually quite rare in Manchester, as most of my colleagues will tell us. The first slide here is that to make the point that children grow. People think of adults with pituitary problems, but pituitary is a problem in childhood, and children grow, so we can actually see the effects of the problems with pituitary in children primarily through their growth. This is a growth chart, and just for those of you who know about growth charts, you don't need to worry about it, but these points are plotted on a growth chart, as you can see, and this kind of tells us that this child's plotted growth is slowly drifting away from what should be the normal lines of growth, and they should be in the blue part. They're kind of falling away. And also, if you look on the right side, there is a red bar on your right-hand side, which shows us the mid-parental height. So parents' heights are very important when we make a judgment about the child's height. So if the child is not growing as per parental height, then we get involved because the pituitary may be a problem here. Just helpful to know that growth happens in 3 different phases. So in the first year of life, for 3 years to somewhere around the time of puberty when children are in secondary school. So between 3 and say 11, we see this phase which is growth hormone dependent. And if your child has a problem with growth hormone production, you will see their growth falter. This is very common to catch them, to see them in clinic and make a diagnosis of growth hormone deficiency at this sort of mid-childhood. And then the other phase is also really important, is puberty, when they have a big spurt. Now, it's not just growth hormone, also the other hormones, the puberty hormones, the testosterone in girls, estrogen. This is what pushes their height up. And if that's not happening, then again, we need to be a little careful. So a bit of anatomy, but this is through the eyes of a radiologist. And this is an MR scan, a magnetic resonance scan of the brain. And the reason why I show you this is it is helpful to know where the pituitary gland lives. It's right in the center of the brain. And it has got, if you look at the front part, is a bit gray. The back part is relatively more white, and it makes a number of hormones which are here. So the blue here is growth hormone. It's the biggest contributor amongst the pituitary gland. The others are the puberty hormones, actually called LH and FSH, and they obviously drive the other hormones from other glands. But these are some of the hormones. The reason why I've kind of put these in orange is these are perhaps the most important hormones, and we'll come back to the stress hormone in particular because it's something you can do if your child has a stress hormone deficiency or cortisol deficiency. It is really important to recognize it because the treatment is simple, but needs information, and hopefully Helen will be able to demonstrate to you things that are important, like injecting hydrocortisone in an emergency. So when you think of the pituitary gland, if you think of the pituitary as the front part is gray, the back part is white, sometimes with birth defects. So these are defects from birth. The back part or the posterior pituitary is a white little blob. It's not really in here, it's gone somewhere else. And that's called an ectopic posterior pituitary. And the front part, I'll just go take you back to the previous slide. You can see it's like a little P, whereas in this slide, it's almost flattened out as somebody smashed it down and it's in the little sliver. So that's one of the things you can have, is something that's present from birth. It may not raise its head till 3 or 4 years of age, but it can present in this sort of way. So this is congenital from birth hypopituitarism. And this is a different form. So this child was seeing us for a completely different condition. So for those of you might know, Crohn's disease is a disease of inflammation of the bowels, of the gut. And we knew that this child was growing really well. And at some point, it started to slow down. This was when he was around 10 years old. And we thought, okay, maybe we made a diagnosis of Crohn's disease, and the child wasn't absorbing food. But he appears that he also had a brain tumor. And this is a brain tumor at the region of the pituitary gland, which was taken out. We got the surgeons were very clever. They went through the nose, did a special type of surgery called transsphenoidal surgery. And he's cured pretty much. And that's his scan. That's his scan after surgery. You can see that the tumor has gone. It's completely removed, which is excellent news. But he remains on replacement treatment because of the damage caused to the pituitary gland. So the point of this is that if you don't have congenital hypopituitarism, i.e. from birth, in some children, and Yolanta might expand on that, some children have, this is a young person now, may have brain tumors which will need replacement hormones for a very long period of time, often for life. And this I mentioned, this is a young man who was in, this is a picture from BBC. It's a slightly different condition, but it's linked to the adrenal, the stress hormone. This child had Addison's disease and sadly died because it wasn't recognized. Children with hypopituitarism also can have adrenal insufficiency. And it is really important that these children receive information and they have the necessary training to give injections of hydrocortisone when they need it. And this is a steroid card that we produce. It's on our society is called the British Society for Pediatric Endocrinology and Diabetes, and it's on their website. And I'm hoping that you should be using something like this card, which is very helpful. You can take it to your local hospital if you need. It has all the details of what your medicines are and what your child's taking. So it's a handy little card and comes in great use in times of emergency. But the important things are parents and families need to know about emergency injections, be trained. And Helen and Lottie often do this day in, day out, telling parents what are the sick day rules. If you're down with a virus or COVID or whatever it is, when do you take extra doses of hydrocortisone? So education is really important. And this is where our specialist nurses are really good. So I'm going to stop there just for a little bit of background. I'll stop sharing and then maybe invite Helen, if I can see you. I'm not sure I can see you, Helen.
Can you see us?
Yeah, I can. We can see you now.
Oh, perfect.
Great. If you could tell us a little bit about the adrenal side, it would be fantastic.
Yeah, so hi everyone. So I thought that I would just go over the emergency injection today and what you should have in your emergency kit. So to start with, obviously you should have a vial of liquid hydrocortisone. Okay, so the one I'm using today is just water, so yours will probably be a little bit smaller, but you'll have a vial of hydrocortisone. You'll have a syringe. You'll have a red needle and either a blue or an orange one. Okay, so first off, you get your vial of your hydrocortisone, and what you want to do is you just want to give it a tap at the top, so all that excess liquid that's just in the head of the vial just falls to the bottom. Okay, and then on your vial you'll notice that you have a little blue dot. Okay, so what you want to do is you want to put your thumb over the blue dot and your finger behind, okay, and hold on to your vial, and you're going to snap backwards. So you're snapping away backwards, and it'll leave a clean break, okay, just round the vial, round the top of the vial, just like that. Sometimes if you squeeze, it can shatter. So what you can do is you could get a tissue to put over the vial, and just to protect your fingers for if anything like that happens, okay. Then what you're going to do is you're going to get your syringe, okay, and you're going to open your syringe. Okay. Take your syringe out, and the first needle you're going to open is your red one, okay. Now, we always use a filter needle here, and that's because you're opening a glass vial of liquid. So if you snap that little lid and there's little bits of glass that go in there, what you want to do is you want to filter any of that out before you give it. Okay, so you put your red needle on, which is your filter needle. Okay, so when you pop this needle on, okay, what you'll notice it is a big needle. Okay, so don't panic because it's your filter one. Okay, so then you're going to put your needle into your vial, okay, and you're going to draw up all the liquid. Okay, take it out, okay, and then you can take that needle off. Okay, because you're done with that needle. All that's doing is filtering your medication that you're going to inject. Okay, then get your other needle. Okay, so it'll either be a blue one or an orange one that you'll have in your kit. Open it up. Okay, and what you want to try and do as well is not touch your key parts. Okay, so like the end of the syringe or the end of the needle, you want to avoid touching those. Okay? So you're going to put it together like that. Okay, then what you want to do is you want to get any air out of this syringe. Okay, so you're going to give it a tap to get all those bubbles to the top. Okay, and once you've done that, okay, then you can push your plunger upwards. Okay, which just pushes the liquid to the top. And then depending on obviously whatever age your child is will depend on what dose you're giving. Okay, so you're going to push your plunger until you get to the dose that you want to administer. Okay, and then we're giving this into the muscle. It's a muscular injection because obviously you've got good blood supply in your muscle, so you want to get that hydrocortisone administered and it gets to work straight away. Okay, so we give it in the side of the leg. Okay, side of the leg. So you're going to take your cap off. Okay, and I've got a little sponge here, but we're going to pretend this is the side of the leg, and you're going to go in at 90 degrees. Okay, and you're going to pinch the skin with one hand. Okay, you're going to go in 90 degrees all the way. Okay, and then you're going to push all that liquid in slowly. Okay, take it out and you're done. Okay, and then your emergency kit that you've got, we tell you to keep them in like a little plastic Tupperware box, so you've got everything all together. And then obviously once you've given the injection, you can put all your needles, your syringes, your sharps, you can pop them in that Tupperware box, seal it, and then you can take it with you and dispose of it. When you're at the hospital, they can get rid of it, and then obviously they will give you a new supply when you're discharged. Okay, so that is how we administer the injection.
Helen, thank you ever so much. Jeff, I was going to pass on to Helen because Helen can share a YouTube link.
I think James has just shared it on the chat. It's a link to a YouTube video which I did, which basically just demonstrates what I've just shown you now, how to draw up and administer the injection. So you can watch that, you know, as many times as you need. It's a really good thing to have.
And thank you. Helen, Bethan's also asked a really important question. Is there any advance on an easier injection like an EpiPen?
I know. We get asked that so many times. And if we could give you an EpiPen, we would, because I know it'd make it easier. But unfortunately, we don't have anything, and we're not able to provide anything like that. The easiest one we find is the pre-made liquid vial of hydrocortisone. You can get a powder, a Solu-Cortef, which you have to mix with water as well, and then mix it and then draw it up. And we find that's quite a lot to do if you're in like an emergency situation where you're panicking. Whereas if you've got a pre-made vial, we think that's the easiest one for you to use.
Helen, I'll reiterate that. So if the pre-made liquid you should try and get.
Yeah.
In a difficult situation when your child's not well, you don't want to have the added stress of trying to mix powder and liquid, and it's probably not going to work. And I would panic if I were you.
Yeah.
But yeah, I think there is some thought, and there are some groups who are trying to commercialize an EpiPen type hydrocortisone, and it may be that it comes in adults first and then children later, but would be really helpful, Bethan. I don't know if you've been involved in anything or found it very hard to be able to inject. We did a study a while back and asked parents. We tend to teach them at the initial time of diagnosis, as you said, Jeff, that you were given the information and knew how to inject, but then maybe several years have gone by and there was no refresher. So Helen, you tend to provide a refresher these days and ask people signpost to the YouTube video with the hope that families will pick up the information and kind of look at it again.
Indy, I think Kelly had your hand raised as well. If you
right, okay, perfect.
Yeah, hi.
Hi, Kelly.
I've given the injection to my daughter's now 11, so I've had to give it to her quite a lot when she was a baby. I do find a soft sock on top helps. And once you've given the injection, she's always like, "Mummy, it's fine as long as you can just put that over the top." I wanted to ask. I was always told to put it in the top third, facing up, not the side. Oh, everyone's frozen.
Yeah, I know. It's probably for the internet.
Sorry, it cut off a little bit there.
So Kelly, I'll repeat that again. So I was just asking for our benefit. You've injected us several times, not just once.
Yeah.
So you're a seasoned injector.
Yeah.
But if you wouldn't mind telling us maybe one occasion where it was not so easy, and how do you feel?
I mean, I guess it was the first time I did it because I was really shaky. It was the first time to inject my baby. So that was a bit worrying. But I always keep obviously several near me. I mean, I'm a single parent, so I've got some at my parents' house, some at our house. I'll just go off on a really quick tangent, but I won't take up too much time. I was really lucky when my daughter started preschool and primary school and brownies and guides and gymnastics that the staff were willing to give it in an emergency injection. As some of you might have seen this campaign, that I basically started a petition because her secondary school were refusing to train. But because she's very far away from where we are, it was essential. So I've been really, really lucky because my debate was with Bristol Children's, but actually the Pituitary Foundation have trained school. Otherwise, I would not have felt safe because I know if she needs that injection, she needs it straight away. So when school have said, we'll follow protocol and we'll wait and my daughter's quite clumsy as well. So her primary school have said how she hasn't broken a bone yet. We don't know. And I couldn't risk that because I know how stressful it is anyway, trying to do it. But the more times you do it, you just, it's not open heart surgery. Do you know what I mean? It is worrying. And parents who haven't done it yet, it is that first time, but it is just trying to keep calm and follow the steps like Charlotte and Helen said. I've got some out-of-date vials that I've used with my family members just to go over the refresher. And I guess one of the main things I always find to remember is if you give it and it's not needed, they won't come to any harm anyway, because it's just the liquid version of the cortisol tablet. But yeah, it certainly is nerve-wracking the first couple of times you do it. And I find the younger Isabella was, the more worried I was with her, you know, her limbs being smaller. But now, you know, obviously she's older, so we have a conversation. If you're sick again, we'll have to do it, but it's okay because we know what happens and we'll do that. And then this is what will happen in hospital. But I guess that comes with experience and age of Isabella growing up as well.
Well, Kelly, you're a super mum, is all I can say. It's not easy to be in your position, and I think you've done remarkably well. I think that your tips to have several injections in different places where Isabella goes is really important, because you don't want to, you know, you want to find it as soon as possible if your daughter is not so well. So it might be a good tip to have maybe an extra supply with the grandparents. Your experience with school is, I think we share the same thing. I'm not sure whether our schools in our local patch would, you know, sign up to treatment to give injection. They'll say, you know,
I think it's different, isn't it, in different areas? Because some parents I'm in touch with in different areas have said, well, our secondary school had no problem.
Yeah.
And I said as well, I'm a teacher myself. If I've got a child in my class with a life-threatening condition, as a human being, regardless of anything else, I'm going to do everything I can to do that. And I was just very lucky with primary school brownies and things like that, because it was just like, oh, and I know it's not the same as drawing up Calpol, but in a way, you know, a lot of people have drawn up something and put it in. I know it is scary, but if it's a matter of, I don't mean it horrible, but potentially life and death, until my daughter's gone to this secondary school, I have felt that people would be willing to do that.
Yeah, no, that's a point well taken. I think it's a worthy cause to fight for, because the more you can raise awareness. Sadly, you know, the lad I put up on the screen, I mean, obviously had Addison's disease, but we've also done a similar survey of young people in the Northwest, and we still do have young people dying from adrenal crisis. So it's absolutely worth the campaign you're fighting for. So well done, Kelly.
Thank you.
I'm going to just move you back to Lottie on slightly less worrying things, but nonetheless, it's just to break up the, I suppose, the somber mood. And if you tell us a little bit about maybe growth hormone, Lotte?
Yeah. So I thought I'd just do a little chat about growth hormone. I've had a few older patients actually recently, call me and say that, you know, their growth hormone injections are starting to hurt, and it's not quite as normal as it used to be. And I just thought I'd offer some kind of hints and tips on how to kind of make that better, or if you're having any similar experience at home. Just obviously because the growth hormone is a daily injection, and we know how important it is to have it daily for it to be effective. I just thought I'd offer some kind of guidance on that. So we always recommend growth hormone being given on the front of the legs, and the best position to be sat in is sat down. So some patients sometimes ask me, can I lie down? But what we want to try and get is that kind of fatty layer of tissue, that subcutaneous tissue. And we get most of that when we sit. When we lie down, it kind of all flops to the bottom, and we need it to be lifted up. So we like to be sat. If you could lift the skin as well, or, you know, if your children are getting older and they're able to do their injection themselves, just remind them to lift the skin a little bit before they give their injection. Look out for any wet injections, what we call wet injections. So if there's quite a large puddle on the skin, the needle might not be going deep enough, getting all that growth hormone into that subcutaneous tissue. If they are getting a bit more muscly as they get older, it might be that they need a smaller needle. So most of the growth hormone companies, they offer a 5mm and a 6mm needle. So especially if they're athletic, sporty, you might find they're getting more muscles on their legs. They might be better having the 6mm just to get into that skin. Or if they're a little you know, if they've got bigger legs, they can have the 5mm because we know it'll get into there, but we can't really go any smaller than that because we don't want to be pinching or blistering the skin. Okay, and that's it really. So it's just kind of to open a little conversation about if anyone's experiencing that with their children, or if they kind of had any changes as they were growing up, or if you found anything that helped that you could kind of offer to other people. But yeah, that was it really, just a small little bit from me.
Thanks, Lottie. Yeah, it's helpful. Obviously, there are different types of growth hormone, isn't it? I mean, every child is on a different type, so you can't necessarily generalize, but it's something that parents have to do day in, day out for many years, as long as, you know, as their child's growing. So it's quite a big deal for the family. So Jenny has asked the question in the chat, what about timing of growth hormone injection? How early is too early? I.e., if there is a sleepover, we don't want to miss a dose. Lottie, do you want to answer that?
Yeah, so we tend here in Manchester to not give a set time, but we like the growth hormone to be given in the later part of the evening. So we try to say like a similar time if you can, but say all the time, giving it early in the morning is good. But for one-off occasions, there are adjustments and changes that we could make to the growth hormone, which isn't going to have, you know, like an overriding impact.
Oh, we froze.
Oh, we froze. Yeah, so I was just saying, if it's like they're going to the sleepover early or after school, you can kind of plan for that a couple of days before, and each day bring it forward like an hour earlier. So, you know, you're adjusting the time for that sleepover, or if it's, you know, going quite late in the evening, you could just give it a couple of hours before you usually do of an evening. We wouldn't recommend giving it early all the time, but for one-off occasions, it's not going to make much difference, so you don't miss that dose.
Yeah, thanks, Lottie.
Okay.
Are there any questions? What about your experience? Do your kids also get growth hormone? I suppose I could ask Yolanta if your son had growth hormone when he was growing up.
It's actually, thanks, Indy. Yeah, it's really interesting to hear, you know, stories and things. But it's actually my daughter, and she's had growth hormone from, well, since she was diagnosed. And we've not really had any issues as such, but I think over time, I think because she does rotate where she injects, I think on the front of the thigh, it sometimes seems to reject a little bit. You know, as far as I know, she puts it in, and I know she does put it quite deep, and she's obviously quite used to it, but sometimes it seems to, she sometimes says, oh, I don't think that's gone in very well, but it's almost like this tightness off the, I don't know if it's the muscle or the layer, you know what I mean? Because it's almost like it's been overused in a way. Do you know what I mean? I don't know if that's something you've come across, or if you can give any advice for that. Or
yeah, so you made a really good point there actually that I didn't mention about rotating the sites. So that's a really, really important thing about, because you're giving this daily injection to make sure, you know, you're constantly moving around on your legs where you're giving the injection. And what you might find is, because she's had the injection now for so long, and even though she is rotating these sites, maybe the skin has hardened a little bit. Maybe, you know, at the front of her thigh now, maybe it's just gone a little bit hardened, and maybe that's why she's feeling that slight resistance. But as I mentioned before, by lifting the skin, if I just show on Helen's little pad, if you kind of try and like raise the front of the skin when she's sat down, she might find that just lifts it away from the muscle a little bit and just makes it a bit more easy to administer. But yeah, that's a really good point about rotating the sites. And with the skin going hard as well, you might find some small bruising, some bleeding. And that's quite normal, you know, if anyone else has experienced any of that, that is quite normal. And you know, with time and in different areas where the skin isn't so tough, you might find that doesn't happen. But we have like quite, you know, tiny little like capillaries on the front of our legs, which sometimes we can nick when we're going in that area. So again, if that is happening at home, again, those things are quite normal as well.
That's really brilliant, Helen. Can I just sort of add to that? I know she does sometimes put a cold compress on, just a little flannel, and sometimes that actually makes it a little bit less maybe painful, and it does actually help. So I think that's something that she's going to, keep using on the one particular side, it seems to be. So yeah, that's great. Thank you.
Yeah, like a cold compress is a really good idea, and also with the growth hormone having to be kept in the fridge, maybe just taking that out kind of 20 minutes to half an hour beforehand to let that get to room temperature, because it won't impact the growth hormone, but you might find that also just improves the ease of it going in. Sometimes if it's cold, it can be quite stingy, things like that. So yeah, there's a few things there as well.
Thank you. That's great.
No problem.
Yolanta, can I come back to you? So obviously your daughter has been injecting growth hormone for a while. And a lot of parents are in the same position because there's years of treatment. Do you see sometimes things are flagging, or, how do you keep up the importance of take growth hormone every day for so many years?
I actually, honest truth, I don't actually. I should say my daughter doesn't have any problem. I think that is it. She has been taking it for years, and she just sees it as part of her routine. You know what I mean? She knows that she has to have it in. She's never really sort of said, "I don't want to have this anymore." I've sometimes heard stories of people saying that about their children and things, but thankfully, she has to take it, and we've not had the issues there. But I do know, some people think maybe, I've grown to the height, but it isn't necessarily the height. It's also, for well-being as well, as far as I understand. So, it's still quite vital into adulthood as well.
Yeah, I mean, I don't know if there are other parents who have had a slightly different perspective or experience, but you're right. Some parents do come and say that it's getting harder because their child is now a teenager, and we'll come to the teenage question in a minute, because they start to develop their own identity, and but as Yolanta says, it's not something that you just give for a day. It is for many years, and sometimes quite often into adult life.
It was interesting what you said about the best position being sat up, because I still inject Isabella lying down. That was the way I was always told, but it makes more sense actually to be sat up. I'm also told now that she's 11, if she misses a dose here and there, it doesn't matter. So I haven't. She only likes me to do it. I did recently. I sound like a bad parent. I did go to Marbella for four nights. I did say that her granddad had to inject. She was not happy. He used to do it when she was younger, but I think he did one that stung a little bit, and it kind of, as it would kind of put you off. But actually, she thinks he's done it a lot better. She also went on a school camp, and her teacher did it with no pain at all. So they're actually better than me. I'll try that sat up actually.
Sometimes psychological barrier.
About doing it in the side of her tummy as well, or here.
So we know that like adults tend to do subcut injections like in their tummy. As they get older, that tends to be a common place for different drugs and things. But for adults, they tend to say the belly, don't they? Because I think it's easier to give. For like young people and children, we recommend the legs just because it's easy access to get to. It's a comfortable position to sit in, and also if you do get any bruising or bleeding, it's kind of hidden on your legs. But there is the belly option is there. We don't tend to talk about arms too much here in Manchester, but that's not to say that it's right or wrong. But we just find from majority of our families that the legs is the most comfortable. And sometimes as they get older, into like their adult years, they might also kind of do their belly area as well. But yeah.
I just wanted to flag just before we move on, Indy, I think Jenny had another question in the chat about asking how close we are to weekly growth.
How close we are to having weekly injections. So at the moment we're still in some studies, but not long to go. So if you have a young one who wants to switch, I think just watch their space. It's coming, it's imminent. So Helen and Lottie, we've not been told it's come on to our hospital yet.
No, not yet. But like
not
you said,
yet. So we have a few children on trials that are still running, but it's imminent. So it's a real step forward for children who don't want to inject every day. But it's not going to be for everyone. Some children will still want to do daily, and some children want to do weekly. So, but it gives us a choice to have different devices. So that's great. I think if we could move to on the issue of transition, and thanks, Jenny, for that question. Jolanta, do you want to share your experience about young people?
Yeah, I've just got a few slides, which I'll try and just bear with me a moment.
Yeah, we can see your
Okay, can you see the slides?
Perfect, thanks.
Excellent, thank you. Okay, that's brilliant. Right, hello everyone. I'm actually going to come to the table with two hats on this evening. As you are aware, I'm a parent of actually a young adult now who was diagnosed with a benign brain tumour when she was age 9. So that's quite some time ago. In fact, it's almost 20 years ago next year. So, you know, that the time just flies past. And I'm also going to talk to you very briefly about my PhD study, which is looking at transition from paediatric to adult care, from a children's hospital basically to adult hospital. If you're a parent of a very young child, you probably won't have come across the term transition at the moment. You may have heard of it, you may not have. In fact, some young adults and carers and parents haven't actually come across the word transition as such, but they have moved from a children's hospital to an adult hospital. And it's something that usually occurs around the age of 14 years, but that's only sort of a guideline. You know, depending on what your child's condition is, you know, it could be slightly later than this or quite a lot later than this. And my PhD is really, I must make it very clear that I'm very much at the beginning of my PhD at the moment. And what it is I've decided to look at transition because I did look at transition and chronic illness for my undergraduate degree a few years ago. And when I've been looking at the literature on transition very recently, some of the issues which occurred many years ago, about 14 years ago, still are unresolved. And so it's quite an interesting topic for me. And I think also one of the key things is research on transition for tutor patients is actually lacking. You know, it's not actually... you won't be able to find a great deal at all about it. So transition is actually a process. As I've said, it's a process of moving from a children's hospital to an adult hospital. But it usually happens, as I said, around about teenage years, about 14. But there's also lots of things happening at that time as well. You know, the child could be moving school, maybe going to secondary school, or puberty could be occurring around that time. So it's really complex. So to have to transition on top of that is really quite significant. Parents have very much a key role to play. You know, just because your child moves to an adult hospital, it doesn't mean, you know, they're adult overnight and that you don't have any input. You know, the parents and carers completely the role doesn't really change, but you know, they still have to support and want to support their child. According to literature, there's quite a few things what's required to make transition smooth. It involves planning and preparation, and so a key worker, maybe a specialist transition nurse, to work in paediatric children's services and adult services, should be specialist training ideally. You know, so that they're specialists in the children's hospital and adult hospital, and the models and programs should actually be tailored for pituitary patients rather than just for every specialism. And so the research that I'm looking at really is to understand what the actual needs of pituitary patients are, rather than what's perceived. Slide. I'm just going to really briefly talk about what it's moving away slightly from my PhD study. I'm going to put my parent hat on now. And being a parent with a child with hyperparathyroidism, sometimes, as you can see from the diagram, it looks very confusing. That, you know, when you sort of have the diagnosis, you think, where do I start? There's everything happening at the same time. And, you know, you think about not only a child's condition, the family, the friends, the hospitals they're at, medical supplies, appointments, injection. And it just seems when you first, well, it doesn't change a great deal over time, but it gets better. But it's sort of like everything's thrown on a pile and you just think, where do I start? And how will I deal with all these things? And what I found is that really over time, you know, you really have to think about what's the priority? What can I deal with at that time? You know, what can I do? Who can help? And you sort of have to try and get yourself in a kind of order, an organised order as much as you can, and just think, how am I going to deal with all these things? I can't deal with everything at the same time. And I need to start thinking, well, where do I start? And as I've put on the right-hand side, you know, it's important to build on the good. You know, there are some positives, and not build on the bad, because a lot of bad things, you know, have happened. Your child's been through a traumatic time, your family have seen everything, you know, that's happening around them. And it's kind of really can be a lot of anxiety and confusion, but sort of look on the good, think of the positive things that, you know, the child has had surgery and the only way's up now. And, you know, basically you've got to think, how can we build on everything that's occurred? And so it's not in any particular order at all, but it's relying on, you know, communicating and working with others, getting support, and basically try and do everything you can for your child and your family. And it's really important to question everything. You know, if you have consultations and they suggest medication or whatever, you know, if you're unsure, you know, instead of just agreeing, which is obviously what you want at the end of the day, but do ask and make sure that you get the answer that you'd like. And if you're not, you know, it's important to look at alternatives if they are available as well. I put here practical tips, and these are literally only my suggestions. Everybody is individual, and you know, what works for us doesn't necessarily work for other people. But it's really important, I think, for you to find out what works for you, your child, and your family. So I've just picked up on a few of the issues. We've actually covered the emergency hydrochloroticone injection already this evening. But for us, you know, so it's really important for us to keep in date, make sure the injections are up to date. There's nothing out of date. And as I think Kelly said, you know, it's really good to have any extra ones that are out of date to practice with. You know, you can practice snapping them open, snapping the vials open. Family members, it's good if they can be trained. You know, the nurses are really good at providing training. And if you need any up-to-date training, you know, in our experience, we've been able to go back to the hospital and get some more training, you know, over time, because as I said, my daughter's had the condition for a number of years, and you do have to brush up on these things quite a bit. Going into school and meeting with relevant staff, I mean, for us, it was really good that we were able to go into school and sit down with not only the school nurse and the first aiders and teachers, but talk about my daughter's condition, and go through the protocol we had at the time, and let them ask questions, and let it be a two-way process so that we can discuss what the requirements are for the emergency injection. I mean, we didn't actually have a school nurse who was able to give the injection. So we were able to keep an injection in the first aid room, and I was sort of the first point of call because quite local to the school. So I did say for them to contact me at any time, you know, even though I was working as well, I wasn't too far away from school. So for me, for our family personally, that was something which worked out pretty good. I put down, I check local ambulance service if they've got a red flag list or not. Some do, some don't, and I can't really talk for any other areas. There used to be a red flag system in the area where I am living, but there isn't now. So do check what is available in your area. And I think really key thing is to ensure your child wears some kind of medical thing, or a medical ID on their wrist, a little bracelet. So if they are out on their own, or you know, an ambulance does have to be called, that's something that the ambulance staff will be able to check straight away. Just moving on, what we found as a family was helpful was just to have a medication sheet. And this sounds a little bit formal, but it's not at all. And it's just where we noted down the doses and the times, and it was particularly important for growth hormone, because as we talked about previously, if you're rotating around, you know, giving an injection maybe in the thigh or abdomen or arm or whatever it is, you know, we've all got busy lives. We can't actually maybe not remember where we injected yesterday, you know, and it's something for us which we found really useful. I've got an example of that on the next slide, actually. And just briefly, just hospital appointments, you know, when they are due, you don't always, well, we found we didn't always get letters sent for whatever reason. And if we'd not heard, you know, we'd always keep a note of, if we had an appointment with a consultant and they said, right, I'll see you next year, I'll see you in 2 years' time, I'll see you in 6 months, whatever it was, we'd make a note of it. If we'd not heard round about that time, we would actually just contact admissions or, the booking office and just say, are we due to hear from you, you know, and just double check and see what it is. I would definitely suggest making contact. That worked for us because we didn't always get the letters through at the times for whatever reason. So I'll just quickly move on. This is just something that we've got. We just did it ourselves and just keep a note. It's very formal. You just need to have a little book if you've got it. Just write something down if it comes to growth hormone dose, the sites. You know, you do whatever you want if you find it helpful. We found something like this particularly helpful. So I hope, you know, you can find ways of keeping records for yourself if you'd find that helpful. And that's it. Thank you very much for listening.
Oh, thanks, Alanta. That was really helpful. I have one question from Kelly, but I'll come to hers in a minute. Yeah. I think it's really powerful. You've got two hats on, but you're also addressing a really important issue that not everybody is quite as helpful. The T word transition, you know, government should get it right, but it's not doing it. I'm just going to come to Alex and then Kelly, but we'll talk about the transition because it's such an important thing. So maybe, Alex, if you want to tell us a little bit. Alex, you're back on mute. Okay, so whilst Alex, not sure where, but I will get back to Kelly's questions. Kelly's asked the question that I've been told that even if the injection, I'm presuming this is hydrocortisone, if the injection is out of date, that you could still give it. It also says that on the Pituitary Foundation injection video. I'm going to look at...
that did really, both a doctor I asked, and a pharmacist, and actually I was surprised. I don't because I'm not saying they're but it was kind of like, check the date, and if it's in date, give it. But if it's not in date, give it anyway. I was just wondering about that, because I'm very much like date. Oh God, no.
Yeah.
Get the powder one instead if they're out of stock. I was just wondering what you think about that.
So I'll get back to Helen and Lottie, but look, if you haven't got anything other than the injection, which is out of date by a few weeks, you can still give it. So for tablets, we know that there is a slightly longer shelf life. For hydrocortisone, I don't know what the maximum limit is, which is why we insist on parents saying, please do check injection if it's in date. If not, we'll give you one from the hospital. Of course, I wouldn't want parents to inject something that's 5 years out of date. That would not be in anybody's interest. But if it's out of date by a few days, a few weeks, I think it's reasonable that the manufacturers have a longer shelf life than what it's stated on.
Yeah, I mean, I have been told kind of, months and things like that.
So
we were going abroad at one point, and it wasn't enough. I was supposed to receive a delivery, cut long story short, and then he was like, no, it's absolutely fine. He said, don't quote me. That was it. That's what worried me. He said, don't quote me, but it's fine for months and months. It will be fine. But because I didn't kind of, and you're like, oh.
So what if I've had the discussion with the pharmacist, and she said, 3 to 4 months is reasonable. Beyond that, you probably, I don't want you to give an old injection. I don't know what Helen and Lottie would have to say.
Yeah, we agree with what you said, Indy. I mean, we've had that asked a few times, and like you said, if there's nothing else, if they don't have anything available and they need to give that emergency injection, then, give it. But we normally say a grace period of about a month, really. And obviously just trying to make sure that your injection is in date and, everything is okay.
Yeah, it's the one thing I would say is it's not as if it then degrades into something really hazardous chemical. It's just that it loses the potency.
Okay, so she would, if I gave it, I mean, this hopefully would never happen anyway, but say I gave it 5 months out of date, it wouldn't hurt her. It just wouldn't help her as much as it would when it was in date. Is that right?
Yeah. But this is such an important thing. I don't want people to go down that route. And if
no, it was just, I just wanted to question if there, because I know the liquid one runs out every now and again, doesn't it? And then we have to get the powder, which is fine. I've got stocks of that as well. It should never happen, but you're always kind of like, oh, what if, in a few years' time?
Correct.
That was all I was asking. It wouldn't make her come to any harm if I gave it. It just wouldn't be as good as an in-date one. Brilliant, correct. Thank you.
And I just come back. I don't know if Alex had a question or just a comment, but I just wonder if parents had an issue about transition. Was we often get asked when their kids are, say, 15, 16, that they are really worried that they will now not be seen in the children's hospital. And of course, we've seen your children for the last 15 years. So it's that continuity which is lost, and they think that the adult hospital is a big bad place, which it isn't really, Jolanta, is it?
Not at all.
They're equally nice, I have to say, maybe nicer than us. Jolanta, any wise words to people like Jeff who are a little worried?
I think the anxiety will always be there, you know what I mean? But I think there's always going to be transitions within transitions as well, as you say, Jeff, you know what I mean? There's going to be new consultants, and I think your daughter will be absolutely fine, because it's amazing how children and young adults do adapt. As parents, we always worry a lot more than what they do. believe it or not, you know what I mean? And they amaze us how they cope with everything. And it is always the parents that are worrying a lot more, I think. So, you know, try and go as much as you can with the flow. And, you know, it's really inevitable that your daughter will move to the adult hospital, but, you know, don't let it worry you. And just, you know, I would definitely say get involved as much as you have in the children's hospital initially, or whatever, however long it takes, and just be part of the consultation, be part of the continuous support and care.
Excellent. So Jolanta, one of the things you mentioned earlier on, and it's to do with contact. So sometimes hospital appointments don't come through. It depends on whether you're waiting for a letter or a text or something, and it doesn't always come through to you. And we are equally guilty in Manchester. We've just changed to an electronic new patient system, and that's created havoc in terms of the old appointments haven't migrated, not all of them at least. And therefore we're relying on families to ring us and tell us that, look, we haven't heard. So I think your point that you need to have contact details of your team is really important, even if it's in the adult world. Kelly also, yeah. Kelly, just for your information, we often use a patch. You know, like you have a patch of estrogen, and it's like a little square thing, which we tend to start on a low dose, as Jeff was saying. You know, twice a week we tend to use sometimes a quarter of a patch and gradually build up, trying to simulate what happens in normal puberty. So in puberty, you don't suddenly have your periods on day one. You go through a phase, and your daughter wants to be similar. It's really important that she, you know, we give her confidence, and she wants to wear a bra, and she wants to look like her friends. So it's really important that maybe this is a good time, 11, when you're in secondary school, to feel like your friends. So I think you probably ought to have that conversation with your endocrinologist. The other really important reason to go through puberty is bone health. And that's not really something you see from outside, but it's happening now. Say between 12, 13, maybe not at 11, but 12, 13, until your mid 20s and even early 30s is when your bones are starting to see the calcium and get locked into the bones. And that's the store you have. You build that store from your late teens, mid-teens to your late 20s. No other time in life you can do that. So the couple of things are very important at this age when your young person is going through puberty is to ensure that they have the right hormones. And when I say right hormones, the most important hormone is estrogen. The second thing you need to do is, as far as possible, exercise. And if mobility is an issue, as much of physiotherapy. A bit of sunlight doesn't hurt you. It's quite important. And if you're not getting much sunlight, sadly in Manchester we don't, then a vitamin D supplement may not be a bad idea over the winter or the winter months. So
sorry, Andy, I think you froze in the middle of that briefly.
I'm sorry. So I was going to just to conclude that your bone density is really important as part of the puberty process, which is one reason why you need to look after puberty and make sure it happens. It's something that people don't recognize because you can't see your bone strength from outside. So Kelly, you want to have a little think, maybe a patch? It's very easy. It's not noticeable. Tablets obviously not noticeable. But if your daughter was to have a patch, we often will keep it under the knicker line. So nobody needs to know or see. It's private. And you just change it twice a week, something like that. So it's very common, is well tolerated, and it does a lot of good, apart from a little bit of attitude, which I think we'll have to put up with.
Yeah, I think she'll be fine with tablets because she takes her thyroid and her cortisol with no problem. So if there was a tablet option, probably would go with that if that was possible. It's just, like I said, conversations have just started now. So
it's not an injection if you're asking that question, Kelly.
It's tablet form, is it?
It can be tablet or patch. But the one thing I would say, when she's coming up to having a family, then mind you, her ovaries are there. And at that point, and she'll be old enough to make her choices at that time, there is the option to ensure that the eggs are at the right time and ready for fertility. So that's a conversation she'll need to have. Bethan's asked the question, is this the same for testosterone? Quite right. We talked about estrogen because we're talking about daughters, but if you have a son, which I'm assuming, Bethan, you have, then we start to think of testosterone, but there is also another choice to have these puberty hormones that are made in the brain that you're missing. And do you want to talk about that, Lottie, Helen? Giving injections of these hormones, they're called gonadotrophins, and they're not so easy to do, but you can. Go on, Lottie.
Yeah, so we only actually have a couple of patients on this treatment at the moment. It's quite new for us as well over the last kind of 6 months or so. But here at our trust, we can currently support males with this delay, and it consists of giving 2 additional injections onto the other medications that you already have. So one of them is Bemfola. So if you were to search these, they're actually, as you said, fertility medications, but you would give the Bemfola injection 3 times a week as a subcut injection, similar to your growth hormone. And then after 3 months, we then add in the secondary one, which is called Ganassi, which is a subcut injection, but with a more difficult process. So there's powder, water, you have to give your subcut injection at a 45-degree angle and all of these things, but you do that once a week. So then up until the male has fully developed in the pubertal status, we do that by measuring the testicle size. So they could be on this for up to kind of 8 months to a year. So it would be 4 injections a week of this treatment that we've just started some of our young adults on here over the last couple of months.
Thanks, Lottie.
No problem.
So, Bethan, if you're worrying about so many injections, you could just simply start with a little bit of testosterone, and most people it's once a month of an injection. So if you give testosterone, it does all the right things. You know, boys change down below, and the voice changes, and everything is good from outside. What it doesn't do is 2 things. One of them is the size of the testicles don't increase, because you're just replacing the testosterone that the testicles would normally make. And the other thing it doesn't do is help with the fertility. So most hospitals now are starting to use this when your boys are kind of getting to 14, 15, so that they start to increase their testicular size. That is important for fertility, more than just puberty. But it is, I accept that it's a number of injections, so your young men will have to buy into this, that I am happy to have that many injections, but there is probably the more physiological way to go through puberty and be fertile, and everything will be fine. So something to think about. Your GP may not support this, depends on where you are. At the moment, Lottie, if I'm not mistaken, we're doing it through the hospital rather than through the GP practice.
Yeah, it is. Everything's from the hospital. Yeah, at the moment, GP Savings Fund is all directly from ourselves at the children's as well. If they've already transitioned through to adult services, that's a bit grey area at the moment as well. So they still have to be under us here at the children.
Mm-hmm. Thanks, Lottie. I mean, a lot of medicines down to cost, and there is the grey area. Again, one of the perils of transition is what's a child and what's an adult, and it's not well defined. And I have to say that as much as we try and improve this, there isn't a huge effort from the government side to synchronize both of the services together. And I think that's a bit lacking. And that's probably one of the things that Jolanta is leading on. How can we make the services better? How can we make it seamless so that parents like Jeff don't have to worry about it, think of being a bad dad? Thanks for staying up quite dark and late.
Yeah, agreed. So I'll just do a little. I'll just say thank you for tuning in, basically, and thank you to our amazing speakers, Lottie, Helen, Jolanta, and Indy, for all of your just amazing expertise, knowledge, and experiences. It's been completely invaluable. And thank you so much for all of you for taking the time to join us and ask your questions. And so, like I said before, all of our sessions will be available to watch on YouTube and on our website at a later date. Please feel free to head over to our social media channels as well, and to our website to see all of the other sessions for the rest of the month, as well as like some resources. We do have a page on fertility and on hyperpituitary as well. So just a little plug. We are really proud to be able to bring you a month's worth of different informative workshops and online sessions for free throughout Pituitary Awareness Month, but we do rely heavily on the kind donations of supporters. So if you found this session useful and are able to do so, please consider donating to the Pituitary Foundation by texting Living Well 10 to 785 to donate £10. Text costs £10 plus one standard network rate, and we do really appreciate anything you can give. But of course, we do make the sessions free so that you can attend as many as you wish throughout the month. And so don't forget to check out the rest of the programme. It's on our website, buy tickets, buytickets.at/the Pituitary Foundation. And that's all from me. So thank you again, especially to our speakers and to everyone who joined. And I hope to see you again soon.
Well, thank you. Thank you very much.
Bye.